Thank you for joining today. I'm Dr. Durga Sigal. I'm a consultant pediatrician at Queen's Hospital, and I've got allergy interest. Today, we're going to talk about food allergy in children. Um, I've divided my talk in two sessions. And the first one, we are going to talk about overview of food allergy. I'll talk a little bit about the history, diagnosis, and management of food allergy. And then at the end, I'll talk about allergy prevention. And the second part of the talk, I'll be talking about milk allergy. So the way we are planning to run the session is when I finish the first part of the presentation, we'll give some time to ask questions. So you can ask me question either with your unmuting your mute button, or you can put your question in the chat box and Bola will help me to ask the question. I'll try to answer my best. And then second part will be milk allergy, and you'll again the same thing we'll do. You can ask me some questions and we'll wrap up the session. To start with, is allergy and intolerance. These two terms are interchangeable most of the times, but allergy and intolerance is completely different things. So allergy is immune-mediated hypersensitivity reactions. And the key feature of allergy is reproducible. So every time you expose to this food protein or any offending protein component, you will have the same reaction. On the other hand, intolerance is not immune-mediated. Most of the time is enzymatic. One of the common example is lactose intolerance. And this is again the hypersensitivity reaction. So the key feature is allergy is immune-mediated and it's always reproducible, and intolerance is non-immune mediated. Allergy is two types of allergy, is IgE mediated, where there is IgE antibody in the body, and another is non-IgE mediated. In the next slide, I will talk a little bit more about IgE and non-IgE mediated allergy and how we differentiated between those two. So IgE is immediate type of allergy, and non-IgE is a delayed type of allergy. So immediate type means when you're exposed to the food protein, the reaction happens immediately. It's most of the time within half an hour, but it can happen within 2 hours. Whereas in the delayed type of reaction, we don't get immediate type of reaction, but the reaction can happen after hours or even days, up to 72 hours. In IgE mediated type of allergy, the reaction is either skin involvement, which could be urticaria, angioedema, or pruritus, or if the reaction progresses further and turns to be severe type of reaction, there could be organ involvement, like respiratory system, in which the child can present with a cough, difficulty in breathing, and wheeze, or there could be cardiovascular involvement and loss in blood pressure, and that can give you the drowsiness and collapse. So if there is a skin involvement plus system involvement, that is called anaphylaxis. On the other hand, non-IgE type of allergy, you do not get immediate type of allergy, but most of the time, either you get skin symptoms, or for example, eczema maybe flare up after some time, or predominantly we get GI symptoms. That means reflux, constipation, diarrhea, or bit of blood in stool. For IgE mediated allergy is well-defined mechanism. In what happens when the allergen is exposed in the body, antigen presenting cells present those allergen in the epithelial cell, and there's a complex immune mechanism happens where T lymphocytes and B lymphocytes play important role. And the B lymphocytes convert themselves in the secretory plasma cell, and when allergen is exposed again, this plasma cell produce IgE antibody and reaction happens. And most of the time the reaction happens because of the mast cell degranulation and histamine release in the body, which can give wide range of skin and systemic symptoms. In non-IgE type of reaction, we don't know exactly how the symptoms occur and the mechanism is not very clear. IgE type of allergy are easy to diagnose. There is usually typical history of reaction, and there are some validated tests, for example, skin prick testing and IgE testing, where we can measure IgE level. On the other hand, non-IgE type of allergy is harder to diagnose. Most of the time is based on the history, and clinical suspicion. And there are lots of times the symptoms can overlap with other conditions, for example, lactose tolerance and other different types of food intolerance, the symptoms overlap. There is no definitive test for non-IG type of allergy. And the key feature of IG type of allergy, as I mentioned earlier, is reproducible. Every time you're exposed with the allergen, we get the same symptoms. But non-IG type of allergy, you do get symptoms, but the threshold can be different. For example, non-IG type of milk allergy, the child may tolerate a small amount of milk, but if you get larger amount of milk, the child may not tolerate. So it's threshold dependent at times. What are the common food allergen? We say 4 main allergen or 6 main allergen. So the most common food allergen in children are milk, egg, wheat, and soya. We call it as a 4 main allergen. And sometimes we do call 6 main allergens, so that can extend to peanut and fish. So milk, egg, wheat, soya, nuts, and fish. And there are lots of other allergy, for example, tree nuts, cashew, pistachio, almond. Shellfish is another common allergy. Usually you don't see in the very young children because they don't have shellfish, but in older children and adults, you do see quite a lot of shellfish allergy. The food commonly caused delayed type of allergy are milk, egg, wheat, and soya. So milk, egg, wheat, and soya can cause immediate type and delayed type of allergy. And most of the time we do see milk, wheat, and egg causing eczema flare-up and other GI symptoms. Natural history of allergy is changing, and we are seeing lots of new allergens. The child can react with any food, but there are certain foods are more common, as we discussed in the previous slide. But we are seeing more new allergen, especially lentil, chickpea, and peas. I have seen this allergy is more common in the Asian children. And we do also see allergy to kiwi and in fruits and vegetables. And the allergy to kiwi is usually mild, and most of the time is oral allergy syndromes when the children are sensitized to aeroallergen. And we also do see allergy to sunflower seed, pine, sesame, and any other fruit. If you look in other part of the world, there are different food may cause allergy. Especially there's interesting fact. Oh, of course, I lost it.
You're still here with us.
But I lost the slide from my computer. I don't know what happened, but let me just bring it.
Have you got it back?
No, I got it back. Sorry.
Okay.
You can see, isn't it? Can you see?
Yes, I can.
Yeah.
Yes, we can see.
For example, it's interesting in Japan, there's allergy to bird's nest. Apparently, they make a soup from the bird's nest and drink it. So I talked earlier briefly about signs and symptoms of food allergies. So the immediate or IG type of allergy, you predominantly get the skin symptoms, which can be pruritus, urticaria, rash, or angioedema. And then you get the systemic symptoms, for example, respiratory symptoms, rhinitis, sneezing, itchy eyes, cough, wheeze, difficulty in breathing. So, and in gastrointestinal system like vomiting. And if you have a cardiovascular involvement and blood pressure drops down, the child may be drowsy and loss of consciousness. So if there's involvement of skin symptoms plus systemic symptoms, respiratory cardiovascular symptoms, that is classified as anaphylaxis. In delayed type of food allergy is most of the time skin symptoms, is generally eczema flare-up, and the wide range of gastrointestinal symptoms, which ranges from diarrhea to vomiting, reflux, food aversion, bloating of abdominal distension, abdominal pain, and child may be present with inconsolable cry. And if we leave the children with exposing to the food allergen, which they are reacting, and the children may present with faltering growth. And then some children may present with the food aversion as well. How common is food allergy? If you look different studies, population-based studies, they report slightly different. So generally, the prevalence of food allergy around 5% in the UK. This is a paper from the last from Michael Perkins in 2016, who found that 7.1% food allergy in the breastfed and infant, and 1 in 40, that is 2.5% to peanut, and 1 in 20, that is 5% to egg. But roughly the prevalence of food allergy is 5%. But that is a true allergy. But you may have noticed as well, lots of people self-report their symptoms and they self-diagnose that they're allergic to food. And generally around 20% people report that they're allergic to food, but they are not actually. The true incidence of food allergy is around 5%, but the self-reported symptoms you can see in around 20% people, that is 1 in 5, but they are not true allergy. How do you diagnose food allergy? For any disease, the history is the most important, and then support your history, then you request a diagnostic test. Exactly same thing applies in allergy. So you diagnose with the history, and history is even more important. The typical history you ask when you're taking when seeing a child with allergy, the first thing is when the allergy started, when the child was exposed to the food, when the first time the child exposed to the food and the child start reacting, or it happened in the subsequent exposure. Sometimes the child may not react in the first exposure if the child has not been sensitized with that food. But if the child is already sensitized to that food protein, then the child may react with the first exposure. As you know, the sensitization can occur from the skin root, especially children with the eczema. So they may not have eaten that food before, but they may be sensitized with the skin root or in the respiratory epithelium. And it is also important that what was the amount of food child was taken before child reacted. If the child reacted with a very, very small amount of food or trace amount of food, the chance of child having the severe reaction is high. But if the child is reacted with a large amount of food, it may not be the severe type of allergy. So in what exposure is the first exposure or subsequent exposure, the amount of food is important. And the other important thing is how long after exposure to food the child started to react. So that will help you to distinguish whether immediate type of reaction or delayed type of reaction. That means whether it's IgE mediated or non-IgE mediated. In IgE mediated reaction, the reaction happen immediately within 30 minutes, or sometimes it can be within 2 hours. Non-IgE type of allergy, it can happen later. And what is the type of reaction? If there is urticaria, angioedema, or any systemic involvement, respiratory, GI tract, or cardiovascular, then it's more likely to be IgE type of allergy. But if it is a delayed type of reaction, for example, child started to vomiting, child is constipation, or eczema getting worse, then it is a delayed type of reaction. So these things will help you to determine what is the type of allergy and if the child is allergic to food or not. And then once you establish this in history, then you order the investigation. In allergy, there are only mainly 2 investigations we do. One is skin prick testing, and another is specific IgE. If you have got the capacity and expertise to the skin prick testing, it is a much easier and it is most commonly used diagnostic tool for the allergy. It's easy to carry out, usually done in the forearm, as you can see in this picture. Sometimes it can be difficult, for example, if the child has extensive eczema on the forearm, you may not be able to do it, but you can do it at the back as well. So any part of the skin in the body, you can do skin prick testing. In skin prick testing, you do as a positive control and negative control. In positive control, we give histamine, as you can see in this picture here. In the histamine, the wheel is forming, and negative control is the saline drop. So the child should not be react with the saline. That's a negative control. And then you inject in epidermis the allergen extract. You can do multiple allergy testing at the same time, 10, 12, whatever number. You can use the both arm. Once you inject the allergen, you wait for another 15 minutes and read it. Read mainly the wheel diameter. If the wheel diameter is 3 millimeter or more, it is considered a positive result. Is less than 3 millimeter is a negative result. So it's a quick, and then you can get the result immediately and then discuss the finding with the family at the same time. There are certain circumstances you cannot do skin prick testing, especially if the child has taken antihistamine. It's a long-acting antihistamine, for example, cetirizine. Child should not be taking for more than 5 days. And the short-acting antihistamine, for example, chlorpheniramine or Piriton, child should not have taken for the 72 hours. Otherwise, the test result will not be valid. And the second test we do commonly, and probably you must have done it many times, is a specific IgE, in which we measure a specific IgE against that food protein in the blood. A specific IgE is not easy to do. The child needs the blood test, and it's always not easy to do the blood test in the children. You can do multiple tests at the same time. And specific IgE is more expensive than the skin prick testing. For the one specific IgE to particular food allergen, for example, peanut, it costs around 11, 12 pounds, but skin prick testing is much cheaper. In certain circumstances, you may not be able to skin prick testing. As I mentioned earlier, if you got the skin, there's no area in the skin, you can do skin prick testing. In that case, you can do specific IgE. Or if the child has a severe allergic rhinitis or other symptoms, and the child cannot stop antihistamine for the skin prick testing for 4 to 5 days, and in that case, you can order a specific IgE. For the specific IgE, 0.35 kilo international unit per liter is a cutoff. If the result is above 0.35, is considered as a positive result, and less than 0.35 considered as a negative result. And there are other tested, for example, component testing is coming more frequently in the use now. We do in secondary and tertiary care. In component testing, you can test individual protein component of the food. And lots of time you may have a positive skin prick test or a specific IgE due to sensitization, but that may not show the true positive result. In that case, you can request component testing and test a specific protein component of the food. For example, in peanut, a specific protein component is called ARA, after the Latin name. So there are ARA2, ARA6, ARA8. So if you do ARA2 positive, and that means specific to peanut, but ARA8 may be sensitized. So if the child has an ARA2 positive, but ARA8 negative, then it is allergy to peanut, but ARA2 is negative, but RS is positive, that is likely to be sensitization. It is really helps when you're thinking about putting a child in food challenge to make that decision. There are other tests coming, emerging tests. It's called BAT and MAT. BAT is basophil activation test, and MAT stands for mast cell activation test. In the UK, these tests are not done in clinical practice at the moment. They are mainly in the research base. I think in the US, they do in some centers, but it's not in the clinical practice yet. The gold standard to diagnose the food allergy is the double-blind placebo-controlled food challenge. That is the only way you can confirm that whether the child is positive or not. So in that case, the child does not know which food child is having. For example, if you're suspecting milk allergy on the child, you give milk containing food to the child and see whether the child will react or not. If the child reacts, then the child is allergic. If the child does not react, then the child is not allergic. So in that case, you can forget the test result. If the test result is positive, but the child does not react with that particular food protein, and that means child is not allergic to that food. So just to mention, in around 50% of the case in allergy, you do get false positive result. The test result may be positive. The child may have a specific IgE in the blood. That means due to sensitization, and not necessarily child will react with that food protein. Few important points about allergy testing. So once you take the history and then you test the suspected allergen. So if there's a clear history of milk allergy, child was exposed to milk protein and child started to react, then you think that child may have child likely to have milk allergy. And just to confirm your diagnosis and to see the level of allergy, you request for a specific IgE skin prick testing. Never request any test if the child is already tolerating the food. For example, child is already having milk in the diet, and the parents ask you to do the allergy testing to milk. Don't request that test because the test may be positive in that case because the sensitization, but the child is already having milk, so that means child is not allergic to that food. And what happens sometimes, the allergy tests are done despite the child is tolerating that food in their diet. And then you go and explain to the parent, look, your test result is positive, but the child is not allergic. That usually confuses parents. And I spend sometimes quite a lot of time to explaining to the parents in my clinic, look, although the test result is positive, but your child is not allergic. And sometimes this conversation can be difficult. And the parents might think that, oh, test result is positive, my child is allergic, and they might stop that food giving to the child. And what that lead to at the end of the day is the child may lose tolerance, and after a few months or few years, child may be truly allergic. So we should not do allergy testing. The child is already tolerating food. In certain circumstances, we do allergy testing if the child is still eating the food. That is one of the typical examples is eczema, especially in the young baby. The food may be the problem for the eczema flare up. So in that case, we request the specific IgE to common food like milk, egg, and wheat to see the level of specific IgE and whether we should take the food out from the child diets until few months to make the eczema better, and we can reintroduce the food later when the eczema control is good. So lots of the time when you do specific IgE or skin prick testing, the test result may be positive, which is due to cross-sensitization, not due to cross-reactivity. And as I mentioned earlier, on the 50% of times, sometimes the test result may be positive, but there may not be any allergy. So this table we usually help us to determine when you put the child in for the food challenge. So there are different food. For example, if I take the typical example of milk in more than 2-year-old child, if the skin prick test will diameter is 8 millimeter or specific IgE is 15, and this child has a 90% chance that be positive to milk allergy. But look the number. What we consider is skin prick test will diameter 3 millimeter or more is considered as a positive result. But if this child has a will diameter of 8 millimeter or specific IgE 0.35 kilointestinal unit per liter or more is considered positive, but this child has a specific IgE 15. In that, still the child has a 95% chance of having allergy. So this helps us to guide us to determine whether we put the child on the food challenge or not. A little bit about atopic mask. Atopic mask talks about natural history of allergy disease. So what happened in the allergy comorbidities? The main 4 types of allergy comorbidities are food allergy, asthma, eczema, and rhinitis. If you look in this graph, the horizontal line or x-axis is the age, and the vertical line or y-axis is the incidence of allergy of that particular condition. If I take the example of eczema, the blue line, you have seen that the eczema is quite common in the babies, especially 1 to 2 years of age, and they might have a mild eczema, a bit of pruritus, dry skin, or here and there eczema patches. And the incidence of eczema rises in the first 2-3 years of life. As you can see, the graph is going up. And the incidence will gradually come down. Most of the children with the eczema gets better after 2-3 years, and the eczema gradually get better, and in some people it persists in the life. Similarly, another example is the food allergy. In the red line here, the food allergy incidence goes up in 2-3 years, and then it gradually come down and persist in lower level later in the life. It is mainly due to the milk and egg allergy. As you can see that milk and egg, most of the children with the milk and egg allergy, they grow out of it. But some children may develop with the nut allergy and other food, and their food allergy persists later in the life. The other example you can look, asthma in green line here. The incidence of asthma or viral induced wheeze increases in the first 4-5 years of life, and we do see many children with a viral induced wheeze, but these children will grow out of their viral induced wheeze when they start their school or 5-6 years of age. But some children will persist these symptoms later in the life and develop asthma. On the other hand, if you look allergic rhinitis, and the allergic rhinitis symptoms you do not see in the children in the first 4-5 years of age, because they don't get sensitized in the first few years of life. Once they start get sensitization, they start showing the sign of allergic rhinitis. And the allergic rhinitis, as you see in this orange graph, the incidence will go up in later childhood, adolescence period, and in adulthood, and persist. And allergic rhinitis symptoms persisted throughout the life. So what does it tell us is most of the allergy, eczema, food allergy, and viral induced wheeze, children grow out of it, and and grow out of this allergy, but allergic rhinitis, it persisted later in life. So I'm going to talk about a bit of management, overall management of food allergy. There are many guidelines for the food allergy management. Different allergy academy has produced different allergy guidelines. You may have your own guidelines in the primary care. In secondary care and tertiary care, we use BSACI, which is the British Society of Allergy and Clinical Immunology. It produced many guidelines, and BSACI guidelines are very useful. There's another European body called EACI. There's a World Allergy Organization, so they produce different guidelines. How do we manage allergy, food allergy especially? Once you confirm the food allergy from the history and from your skin prick testing or specific IgE, and then the first thing you do is you avoid the allergen. So whatever child is allergic to any food protein, you avoid that allergen. You advise parents not to give that food protein. For example, if the child is reacting to milk, and then you take the milk out of the diet. But most of the children are allergic to milk, egg, and wheat. And we have to be very careful when we take the food out from their diet, because the milk, egg, wheat, and that very common major food. And when you advise to take these foods out from the diet, and that may have a negative impact in nutrition. I usually involve dietitian very early for the management of food allergy. So we see children in the clinic, we have a 15-20 minute slot. Even in primary care, you have got a 10-minute slot. We won't have enough time to go through the history and make a diagnosis and explain to the parents and go through the food. So the dietitian are very, very useful to go through the parents, how much the child is taking, how much the calorie requirement, and to advise on the food alternative. For example, if the child is, you are avoiding cow's milk from the child diets, then what are the other milk alternative you can give? And we also have to be very careful. For example, if you're taking a milk out from the diet, milk is a good source of calcium. And calcium is very important for the growth of the children. And when you give them another milk substitute, make sure it is fortified, contain enough calcium for the child to grow. And these things can be discussed with the dietetic appointment. And the second thing is we need to manage with the acute reaction. If the child is reacting with that food protein, and the child may have accidental exposure to food when they go to restaurant, school, or other places. And if they have an accidental exposure to food, and how do the parents manage these acute reactions? For mild to moderate reaction, for example, beta pruritus, urticaria, or angioedema can be managed with the antihistamine. I usually prefer cetirizine compared to other antihistamines. So we have two types of antihistamine. One is a sedating antihistamine, another is a non-sedating, and one is short-acting, and another is long-acting. So I prefer cetirizine because cetirizine is a non-sedating, and half-life is 12 hours, so it lasts longer. You can use other antihistamine of your choice, or if you got a particular guidelines in primary care, for example, loratadine and fexofenadine. This other antihistamine is commonly used is chlorpheniramine or Piriton. I won't suggest to give chlorpheniramine to school-going children. If you give chlorpheniramine in the morning, child goes to school, might be drowsy or sleep in the classroom. So in that case, I usually prefer non-sedating antihistamines. So I usually give a prescription of cetirizine, but this cetirizine or chlorpheniramine can be bought over the counter as well. For the younger babies, especially babies, you can give chlorpheniramine, which the half-life is 4 hours, and sedative for the babies, it can be good for sleeping as well. If there's a history of severe allergic reaction / anaphylaxis, then we have to prescribe EpiPen. I'll come a little bit more detail on that next slide or so. And we'll prescribe these children with EpiPen or adrenaline autoinjector. So when you diagnose food allergy, I always give allergy action plan. I'll discuss that a little bit more in my next slide. There are allergy action plan in BSACI website. If you just Google it, BSACI allergy action plan, you can get this plan, and it's very useful for the family to understand what their child is allergic to and what they have to do if the child has allergic reaction. And we discussed about the nutritional support, and it's very important to involve the dietitian and early. And we tend to follow up these children in our allergy clinic, and we see them in every 6 months or every year, and where we go through the history, if they have any accidental exposure, and we repeat their skin prick testing or specific IgE and see whether there's allergy, they are growing out of their allergy, and whether we can challenge them. Whether challenge can be done at home or we have to do hospital challenge. Because most of the children with the food allergy, especially milk and egg, they grow out of allergy, and unless we challenge them with the food, and you don't know whether they growing out of the allergy or not. In some stage, we need to challenge them. That will be determined by the history and the skin prick testing or specific IgE result. So this is allergy action plan. I briefly talked previously. This is the screenshot from the BSACI website. It is in the PDF format. There are two allergy action plan, as you can see here. The left-hand side is the allergy action plan with EpiPen. So, and the right-hand side, this one is allergy action plan without EpiPen. So it's easy. You can go to the BSACI website and type BSACI BSACI allergy action plan, and you can get this allergy action plan, or you can print some of the copies and handwritten as well. So most of the time it's a drop-down menu and you can get it. So you write down in the top what the child is allergic to, put the name, their date of birth, and this is very good. It will explain to whether the child has a mild to moderate reaction. For example, in what are the mild and moderate reaction, and what you do if the child has a mild and moderate reaction. And it also explains what are the signs of anaphylaxis and what to do if the child has anaphylaxis. And it also mentions the dose of EpiPen here. And you can put the parents' detail, their phone number, and sign it. On the right-hand side, you can see the allergy action plan without EpiPen, and it explains to the parents if there's a sign of anaphylaxis, what to do, and call 999. So if you diagnose allergy in the food allergy in the children, please print out this allergy action plan and give it to the parents. They can copy it, and they can give it to the nursery. They can give it to the school, and so school and nursery also know what the child is allergic to and what to do if there's allergic reaction. And the important question is, you might have experienced many times in your practice who need EpiPen or adrenaline auto-injector. There's a guidelines from BSACI, which we follow in secondary care. And I'll go through in the next slide about it. The most important thing is, who do you give an EpiPen or adrenaline auto-injector? The first thing is if there's anaphylaxis. If there is anaphylaxis, history of anaphylaxis, yes, we do prescribe EpiPen. However, if there is a history of anaphylaxis, but that is avoidable, for example, child reacted with the parental drug, had an anaphylactic reaction with the parental drug, and parental drug is easily avoidable, they can lock the drug away from the child. In that case, the child may not need EpiPen. We don't prescribe EpiPen. For example, child went for exotic holidays and had some mushroom or some other food, and child reacted to that food, and which can easily avoid it in this country, then you don't need. And if there's a clear history of anaphylaxis and you can't avoid this food, for example, common food, allergen, milk, egg, wheat, peanut, and these are easily available food protein, and the child can have accidental exposure, then we prescribe EpiPen. And then the second thing comes to the gray area. So child does not have history of anaphylaxis, but the mild and moderate reaction. And what you do in that case? So in that case, we need to do the risk stratification. And that is mainly determined by whether the child has got asthma or wheeze. If child has a mild to moderate reaction, but the child has got asthma or wheeze, and they are already got a hyperreactive airway, in that case, we do prescribe EpiPen. But the child has a mild to moderate reaction, but there is no history of asthma, or there is no history of reaction with a trace amount, then we tend to not to prescribe EpiPen. In that case, we advise parents to give antihistamine when they have an allergic reaction. So just to summarize, if there is history of anaphylaxis, we do prescribe EpiPen. If there is no history of anaphylaxis, we need to do the risk assessment. And if the child has a history of asthma or viral induced wheeze, yes, we prescribe EpiPen. If there is no, then we advise to give parents antihistamine. So please go through this flow sheet, and it's very useful and self-explanatory. I always go through this flow sheet when I decide whether to prescribe EpiPen or not. So adrenaline auto-injector EpiPen, the dose is either age-based or is weight-based. Less than 5 years, we give 150 microgram. 6 to 11 years, 300 microgram, and above 12 years is 500 microgram. The other way you can do by weight. Less than 25 kilogram, you can give 150 microgram, and above 25 kilo, you can give 300 microgram. How many EpiPen? This question is asked very frequently. But the bottom line is child should have access to 2 EpiPen all the time. In my practice, I usually prescribe 2 EpiPen when I give them EpiPen. The reason we prescribe 2 is sometimes the child may need 2, or the 1 EpiPen may not work, or it failed to fire. We usually advise parents, if they have to use EpiPen, use the EpiPen and call 999 as an emergency, and the 99 paramedics crew will attend very quickly. I usually advise parents to keep the EpiPen with them all the time and put in the piggy bag. If the child goes to school, it can easily kept in the school bag. There's a MSRA guidelines came in 2017, which advised the clinician to prescribe 2 EpiPen, but I'll leave that decision to you. Lots of things depends upon your local practice and your local guidelines as well. But the child should have access to 2 EpiPen all the time. There is a legislation came in October 2017. After that, school can stock EpiPen or adrenaline auto-injector at school. So nowadays, most of the school keep the EpiPen in the school, and they can use if the child is showing sign of anaphylaxis at school. So that's another reason your allergy action plan is very important, so that the school also know if the child is an EpiPen or not and what the child is allergic to. What are the available product in the market? There are 2 products at the moment. Is EpiPen it's been there for many years and is commonly used, and there's another product is Jext. They're similar. They come in 2 strength. EpiPen comes in 150 microgram and 300 microgram, as same as Jext. And these are expensive. I think 1 pen cost around 45 pounds, and their expiry date is around 18 months. And most of the time, children may not use the EpiPen, but it's important to have this adrenaline auto-injector. If there's a history of anaphylaxis, you never know. And you may have heard in the news that death due to anaphylaxis is not common, but it can happen. So this is the way we can prevent death from anaphylaxis. There used to be another product called Amirate, which has been taken from the market 1.5 years ago because there's some problem. It was not firing the medicine. The benefit of Amirate against this EpiPen and Jext that it comes in 3 strength: 150 microgram, 300 microgram, and 500 microgram. And Amirate has a longer needle, so especially the big children or obese children, you can give it Amirate, which has longer needle, but it's not available in the market at the moment, but it might come. The other most important thing is, once you prescribe EpiPen, your roles and responsibility does not end here. You must train the parents how to use EpiPen. If we give the prescription and they don't know how to use, there's no point in it. They need to know when to give EpiPen. You can explain to them and give an allergy action plan, and you must show them how to use it. In secondary care, if most of the time it is done by the allergy CNS. In a primary care, if you got the practice nurse who can train the family, they can train as well. But it is important that you train them. If you ask the manufacturer, they can give you lots of dummy and you can use in your drawer in your clinic, and you can show it to the parents. It doesn't take long. It literally takes 1 to 2 minutes. And I usually advise parents to watch video when they go home. There are lots of video they can find in online, this in the YouTube, or if you go to manufacturer website and EpiPen and Jext website, there are videos and they can learn. And when these children come to our clinic in yearly basis, we take that opportunity to give a refresher training to them as well. So training is very, very important. I have a child in emergency department. The parents gave EpiPen when the child has febrile convulsion. They did not know when to give EpiPen. So it's quite important to teach them when to give and how to give adrenaline auto-injector. This is just for the information. These are the 14 foods which should be highlighted in the food product. If you go to the supermarket and see the food packaging, you see some of the foods are bold or highlighted, and these are the 14 allergens, which are common allergen. This is the UK and EU law. It's come around 2013, 2014, and manufacturer must highlight these foods in their packaging. So we talk about the allergy history, diagnosis, and management. And the prevalence and incidence of prevalence of allergy is rising. And the next question comes, can we prevent allergy? The answer is yes. So I'm going to show you evidence in the next few slides based on these two studies done in the UK within the last decade. So the one study is called LEAP study. It stands for Learning Early About Peanut. So I'll just briefly tell you what this study showed. So what LEAP study showed is, there were 640 children were enrolled in the studies. Is a randomized controlled trial study, and they were either had eczema or egg allergy or both, and some children were sensitized with this peanut. 530 children were sensitized, and there's another group of children who were not sensitized to peanut. And these children were given peanut protein 2 to 3 times a week until they are 5 years of age. So they are randomized two groups. One group continued to get a peanut protein until 5 years, and another group of children did not get peanut protein until they are 5 years of age. So what did it show in 5 years? Those children who are avoiding peanut, the incidence of peanut allergy is much higher compared to the children who are having peanut. So if you can see here in consumption group, the incidence of peanut allergy at 5 years of age is 3%. But in avoidance group is 17.2%. Is more than 5 times higher incidence of peanut allergy in avoidance group. Similarly, there was another study which is called ET study, inquiring about tolerance. There are more than 1,000 children were enrolled in this group, and what they looked in ET study is, if you introduce allergenic food in children diet early, what happens? So children were randomized in two groups. To give food, they were given allergenic food early from 3 months onward. 6 food were given: milk, peanut, egg, sesame, white fish, and wheat. And there's another group of children who were not given these allergenic food until 6 months, which is standard practice. And they looked in the incidence of food allergy in these children in 1 to 3 years of age. And the finding was, those children who were given this allergenic food early, from 3 months onwards, the incidence of allergy to peanut and egg was much lower compared to the children who were given this allergenic food after 6 months. But however, there's no difference with the other 4 foods which was given in this study. So what these studies tell us is, early food introduction is the key thing to prevent the food allergy. So early introduction of peanut and egg help to prevent development of food allergy in children. So previously, the advice used to be not to introduce allergenic food, especially the nuts, until child is 1 to 2 years of age. Now the advice is changed. So we advise to parents to introduce allergenic food, nut and egg, from early, when they start weaning. The standard weaning time in the UK is 4 to 6 months. The parents will decide when they want to wean the child. And when they start weaning, we advise parents to start giving allergenic food early. So these two studies showed that early introduction food is safe. It doesn't have negative impact in child nutrition, and we can prevent the developing allergy to these children early. So when you see these children or parents in your primary care, please advise them to introduce allergenic food early. And the lots of guidelines has been changed now, and we advise to introduce allergenic food early in the diet. So that's the only way we can prevent allergy now. So there's no other way we have prevented this allergy. This question may have been asked you many times. What you do? Are the siblings of child with food allergy at higher risks of allergy? So maybe the sibling has a milk allergy, and the parents may come to your clinic to ask you to prescribe the hypoallergenic food and asking for whether there's other younger child is allergic to milk or not. But the evidence has shows that if the sibling has got the food allergy, it doesn't increase the risk of food allergy in the sibling. So the current advice is, if the sibling has a food allergy, we don't take special precaution. What we advise families is to introduce food early in their diet, as we advise to other children. But the important thing is the families needs to make a plan how to introduce that food into the child's diet, um, because if the child in the family has peanut allergy, that family may be the nuts-free family, so they may not um, buy peanut in house. So in that case, family needs to make a plan to introduce the peanut in the other child, keeping the child who is allergic to peanut. So they need to plan. But the advice is you can introduce these foods early. So that is the first part of my presentation, this overview of food allergy. The second part is the milk allergy. Unfortunately, I'm just looking, the time is already 51 past 6. I'm really sorry, I'm just overly running out of time. But whatever it is, we can take a break and you can ask me the questions now.
Okay, we've got 3 questions here for you. And
Yeah.
one of the questions says, I understand we should not be prescribing extra EpiPens for schools and only required amount to be carried out with child at all times rather than kept in the school office. Please advise. Thanks.
So it's a guideline. So previously, what the advice was there's a tendency to prescribe 4 EpiPen, 2 for home, 2 for school, and most of the time children do not use EpiPen. It's very rare, and then what happens? The EpiPen expires in 18 months and is 40-45 pounds. So that's why the practice has changed now. So school can keep the EpiPen at school. And if the child has anaphylaxis reaction in school, they can use. But usually what we can advise is we can prescribe 2 EpiPen, and the child can take that EpiPen with them in the piggy bag and the school bag.
Okay, thank you. The other question I have is, in my previous practice, I came across multiple cases where their parents wanted their child to be tested for allergies with ongoing eczema, asthma symptoms, where the history was not very obvious and the trigger could not be easily identified. The policy in that practice was that we should not be requesting allergy tests, but refer to secondary care allergy for this. What is your approach to this? Are you happy to receive referrals for allergy testing with no HX of anaphylaxis that is more straightforward? Or
Yeah.
what approach would you recommend to GPs? Thank you.
Thank you. It's very important questions. So the answer is it depends on your expertise. If you are happy to request the test and happy to interpret the result and advise the parents, you can request specific IgE. But we have to be very careful when you're requesting the specific IgE, because the child may not be allergic to it, and the test result may become back positive, as I mentioned, as I highlighted earlier. And most of the time, children with the eczema, they can be sensitized with the lots of food allergy, food protein, and they may not be truly allergic. And in very young children, especially in the babies, the food may be the culprit for the eczema flare-up. So in that case, to control the eczema, if it is a very severe, we request a specific IgG to see. But if there is no clear history, if the parents are coming to ask to request for a specific IgG, then if there's no history, then I would not request. In that case, if you want to refer the child to the secondary care, we are more than happy to accept that referral and have a look in the child and decide whether the child needs to be tested and discussion to have with the parents. So the answer is yes. You not to have the allergy testing and refer to us, and we are happy to go through it. But if the child is already tolerating food and there's no history of allergic reaction and the parents will come and ask for the allergy testing, please don't do it, because that will confuse lots of things. But if you want to refer for the second opinion, we are more than happy to accept those referrals.
Thank you very much. Do anyone have any questions they would like to ask? If you do, please unmute yourself and ask that question. Anyone that has any question, Please, this is.
Hi, this is one of the GPs from Redbridge. I do have a
Hello.
question similar to what just been answered, but a bit more specific to the point that I come across a lot of parents who would say that their children are showing some symptoms to certain food. Say, for example, they started weaning and they've noticed they're having some, nothing serious, but some reaction to strawberries or things like that. Is that a direct referral, or what do we do in that case? It's a minor reaction. There has been no report of anaphylaxis, and the child is well. What would be our approach in that kind of a situation?
So it depends upon the food, what the child is allergic to. For example, if it is a major food, milk, egg, wheat, and other foods, then probably that is important. That can have an impact on the nutrition. But if the child has a very mild reaction with the fruits, for example, you mentioned with the strawberry, and the reaction to vegetables and fruits are usually the mild, and it's a single food allergy and it has not a massive impact on the child nutrition, then probably you can manage the child in the primary care with the allergy action plan, or advising parents how to manage the allergy. So basically for these mild symptoms, you can manage with the antihistamine as and when requires. But if there's a history of allergy with the major food allergen, for example, milk, wheat, and egg, and then the child is showing the sign and symptoms, then probably you can refer the child with the dietitian, and the first is the one approach, and you can refer to us as well if it is a major food, and we're happy to see this child. But for the minor reaction, not a major food allergen, then probably you can manage in the primary care. For example, if the child come to my clinic with the strawberry allergy or the kiwi allergy with the oral allergy syndrome, so basically what I do is I don't do usually testing. I just educate parents, explain about their allergy and how to manage the allergy for the mild allergy symptoms. And many children with the mild symptoms can grow out of it. The other important thing about the food allergy I didn't mention earlier, when you advise parents to introducing allergenic food with the milk, egg, and wheat, and soya, especially when they're weaning, the important advice you give is just introduce one food at a time. I have seen that lots of times, especially in the nut allergy, the parents give the first time mixed nut, which may contain peanut, cashew, or almond, and the child react. And you don't know whether the child is reacting with the peanut, cashew, or almond, so because the child was having mixed nut. The important advice is to advise parents to introduce one food at a time. And the other important thing is when the child is well, and never, as parents should not introduce any allergenic food in their diet when the child is unwell with the viral illness. As you know, the most common cause of rashes in children is the viral illness. And children do get lots of viral illness, especially in the winter months, and they get rashes. If the child having having viral illness and the parents give the food, allergenic food, and the child develop rashes, you don't know whether it's due to the viral illness, viral rash, or it's a true allergic rash. So it's quite important to tell the parents that introduce one food at a time. And the second thing is do when the child is well. And there's no rush. They can introduce one food at a time. For example, if they're weaning on the egg, is to give egg a small amount first. So they can start with a small amount and gradually build up. And the other important advice of introducing food is baked products are less allergenic than the fresh product. So what happens when you cook food, the epitope, protein epitope, usually protein is allergic, the epitope, the structure of the protein changes when you cook food, and it becomes less allergenic. So when you advise parents to introduce egg, I usually advise to give them to baked product first. For example, you get cake or well-cooked omelette or well-cooked scrambled egg. And if you cook them longer, it becomes less allergenic. So you always start with the baked product and then gradually go to less product. So that will be another advice. And I'll talk a little bit more about the milk in my next presentation. I hope that answers your question.
That does. Thank you very much. Sorry, just what you said, based on that, I've one very quick question as well about the oral allergy syndrome.
Yes.
What should be the advice? Because I have come across a couple of patients who mentioned that. So is it they totally avoid it, or can they also have it in a slightly cooked or washed, or what do we do?
So the answer is second part you mentioned. So oral allergy syndrome, if you look for the pathophysiology of oral allergy syndrome, is mostly due to the sensitization with the pollen. And you do get most of the time oral allergy syndrome with the fruits and vegetables. So the kiwi is the most common I've seen in my practice, and the others are like apple. What do you see in these children is these children that also has a sensitization with the aero allergen. So they have allergic rhinitis symptoms. And due to the cross sensitization, these children exhibit the sign of allergy when they have these fruits and vegetables, especially kiwi and apple. The advice I usually give it, they can peel the skin off, and that can make the less allergenic. And also they can boil the food or warm the food in the microwave for 30 seconds or 1 minute, and that makes the food less allergenic. And they can continue to eat this food. So they can take this method, taking the skin off, boiling the food, or they can also have this processed food. For example, if the child is showing the oral allergy syndrome to apple, fresh apple, but if the child is having canned apple, then the child may not be reacting to this one. And it is very common to the fresh fruits. As long as they can tolerate the symptoms, they can continue to have it. They should not, they do not necessarily need to avoid it. It's the individual choice. For example, I personally get oral allergy syndrome with the kiwi, but I continue to eat. So as long as they can tolerate, they can continue to eat the food. And in oral allergy syndrome, the reaction usually does not progress further, and you don't see an anaphylaxis type of reaction with oral allergy syndrome. Yes, they can continue to eat the food as long as they tolerate.
Thank you very much.
One question, please. This injection EpiPen, until now, we used to use only 150 and 300, depending on the age. But is it everybody over 12? You recommend now 500 micrograms?
So that's a very good question. The recommended dose for the adult and children above 12 years is 500 microgram, but we don't have that product available in the market at the moment. We used to have Emirate, but it's taken off from the market 1.5 years ago. And the current practice is above 12 years, we give the 300 after 6 years, we give the 300 microgram, or even after 12 years in adult population also, we give above 300 microgram. But the advice you can give, if they use the one EpiPen, 300 microgram in the older children, and they are still having the symptoms after 5 minutes, they can give the another EpiPen. But we don't have the product, and the advice is just to give 300 microgram first and see.
Thank you so much. Excellent.
We've got one last question and we'll wrap it up. Is it possible for minor reactions after multiple exposure? It leads to severe anaphylaxis.
So it could happen. So what would happen is if you expose with the food protein for the first time, the child may not be sensitized with that food. So in multiple sensitization, the child may react further. And the other instance is, initially, if you get a small amount of food, and if you increase the amount of food, the reaction may progress further. So that is why it is important. So it can happen. That is why we just need to tell the parents and make them aware, and so that they can recognize the sign of severe symptoms. But if there's a history of mild reaction, or the child is reacting to the food, we advise not to have that food and continue manage with the antihistamine. So that's how it exactly happens. So if the child has a mild reaction, the parents can give antihistamine first. And if they see any sign of anaphylaxis, as per in the allergy action plan, any respiratory or cardiovascular involvement, and they will give EpiPen. So in most of the times, in the first instances, if there may not be anaphylaxis reaction, and they can give antihistamine first, but if there's a sign and symptoms of anaphylaxis, then they can give EpiPen.
Thank you very much. I think what we'll be looking at, I think we'll be calling it a day. I know we've run out of time. So thank you everyone for attending today's session. I hope you find it useful and beneficial. If you've got any further questions, you can send those questions to me, and I'll be more than happy to pass it on to the consultant who will be able to answer those questions for you. Are you happy for me to share your email address with the delegates who are attending the session today, or not?
Yes, I'll be very happy. So you can email me if you've got any questions. So I'll try to answer my best. And apologies, and it meant to be 2 sessions for milk allergy. I thought which will be very important for the primary care, but sorry, I could not finish it. It's been already 7:05, so you may have other commitment. But I have got the presentation ready, and I'll be happy to do that presentation the next time when you have time. So just do let me know. And then we can arrange another session. So I can do the milk allergy.
Okay, what I will do is, because I've got the dates planned or out anyway. So what I will do is I'll look at the next date we have for the pediatric one, and we will put that as the milk. For the milk allergy session. So I'll liaise with you. What will happen today is the presentation, the first part of the presentation, I will copy that and send that all to the delegates. And the other bit we will focus on. So thank you everyone for attending today's session. Today's recording will be made available, will be on our website, and I'll send you today's presentation as well. And if you've got any question as well, I will let you I will send Dr. Sigal's email address. Our email is email address to everyone as well. So if you've got any questions, you're more than happy to kind of send this to him directly. I hope you found today's session useful and beneficial. And thank you once again for attending today's session. And I think that is everything from